What did we do? In this 45-minute presentation, I'm going to demonstrate the link between obesity rates and COVID mortality, and explain why I think that national lockdowns were a completely flawed policy from the start. In 1993, the UK obesity rate was 15%. Here is a graph showing the age-standardized mortality rate per 100,000 people from 1981 to 1993. Obviously, it's not fair to compare the number of deaths between different years if some years have a more aged population, so these numbers can be compared to each other fairly without having to worry about the age profile of the population. You can find these figures on the government's ONS website. You can see the mortality improvement for the period. 93 was actually quite a bad flu year worldwide, and the UK has seen higher deaths than normal. Let's fast forward to 2006. The UK obesity rate is 24%, and reports on obesity start to appear more frequently in the news. Life expectancy is going to go down unless we do something. What did we do? 2007, same story. 2008, up to 25%. What did we do? 2009, 2010, 2011, 2012, the focus is drifting onto childhood obesity. Life expectancy is going to go down if we don't do something. What did we do? 2013, up to 26%. What did we do? 2014, 2015, the obesity rate keeps increasing. The news stories are the same. What did we do? In 2016, Jeremy Hunt, the then Health Secretary, described the rise in childhood obesity as a national emergency and promised a game-changing response from the government. What did we do? In 2017, we're told that the UK is the most overweight country in Western Europe. 2018, 2019, the obesity rate rises further still. Life expectancy is going to go down if we don't do something. What did we do? As an aside here before I move on, notice how many of the reports of the UK's obesity crisis are accompanied by a picture of a very overweight individual. The subtle implication here is that the obesity problem is obese people's fault, a message that is both counterproductive and almost certainly false. I will emphasise this point again later. Now, you may have noticed a little-known virus come to dominate the headlines over the last year, COVID-SARS-2, known as coronavirus or COVID-19, which we'll call COVID here for simplicity. Now, I took these 2016 obesity rates for different countries from Wikipedia, and I took these COVID deaths per 100,000 people, also from Wikipedia. What do you think the correlation is? Here is what I found. I looked at different figures. I considered varying sample sizes from the 20 countries with the largest populations, which accounts for 69.23% of the world's people, down to including all countries with populations greater than 4 million people. The UK's population is 67.5 million, which makes us the 21st largest population in the world. So if we're thinking about what to do in the UK, we might want to only consider countries with populations greater than 10 million, say. However, I went down to 4 million because I wanted to make sure that I included New Zealand in the figures, as this is a much talked about country and often cited as a perfect example of the success of lockdown. So what do these numbers mean? All of the correlations here that you see are between 0 and 1, which means we're seeing positive correlation. The closer they are to 1, the stronger the correlation is. Other than the 0.395 figure, which isn't a massively strong correlation, we can see that these numbers are showing a strong positive correlation. This is showing us that countries with high obesity rates were very likely to incur high COVID deaths. It also looks like the correlations are stronger the more we only look at countries that have large populations. I calculated two figures for each row. One is giving each country equal importance, and the other is weighted towards each country's population, which means I'm trying to give each individual person in the world equal importance. I would suggest that the figures on the right are probably the ones we should be looking at, given that it's lives that we're meant to be saving. But I show you both sets of figures, and you can draw your own conclusions. The original data is freely available on Wikipedia, and anybody with an A level in maths or stats would be able to help you reproduce these numbers for yourself. So countries with high obesity rates were very likely to incur high COVID deaths. It also looks like the correlations are stronger the more we only look at countries that have large populations. However, it's important that we don't jump to conclusions. We cannot conclude from this that obesity itself causes more COVID deaths. And we cannot conclude from this that obese individuals are the ones more at risk. But what we can and should do is investigate causation. Something like this is probably going on. We already know about the link between type 2 diabetes and obesity, and I include it here by way of an example. This is often misunderstood as obesity being the cause of the diabetes, when it's more correct to say that a bad diet, high in saturated fat, calories and cholesterol, increases your risk of diabetes by impairing insulin action. This can be true for many seemingly thin people, as well as many obese people. So the main cause is the bad diet, and obesity is more a probable indicator of this bad diet. It might well be that a similar thing is going on with COVID deaths, or it might well be that the obesity itself is causing the high COVID mortality. I want to make it plainly clear that my knowledge of how COVID causes individuals to become seriously ill and then die is no better than that of anyone who watches the news. But we've seen from the strong correlations that there's definitely something going on, and it needs investigating quickly. It strikes me as urgent that we alter the unhealthy lifestyles that are leading to obesity and its associated problems. This is what I think governments should have focused on, and it's what I think they should be focused on now, which I'll talk more about later. Now here's an interesting thing. I went back to the same COVID deaths per 100,000 figures from Wikipedia, and I found a lockdown severity index that's been put together by Oxford University. I used the maximum figure for each country as a proxy for each country's approach to lockdown overall. Now what do you think the correlation is? Here is what I found. There is hardly any correlation. It's a truly counterintuitive result. We would expect that these numbers all lie between 0 and -1, because we would expect that the more severe the lockdown, the fewer the deaths. If lockdown had an impact on COVID deaths, we would expect to see these numbers being quite close to -1, numbers like -0.7 and -0.8. The only correlation here that is even noteworthy is the -0.286 figure, showing a slight negative correlation, and hence evidence that perhaps lockdown is mildly effective in very large populations. Without correlation, the hypothesis of causation is weak. There is very little evidence here that lockdown impacts COVID deaths. Again, all this data is freely available online, and anybody with an A level in maths or stats would be able to help you produce these numbers for yourself. Now I want to make some slight criticisms of my own analysis. I've used COVID deaths per 100,000 people from Wikipedia, which is the data provided by Johns Hopkins University that you hear about on the news. I'm not 100% convinced that this is what we should be looking at. The numbers are very reliant on each country's reporting procedures, which may be different from one country to the next. There may also be inaccurate data in countries with less rigorous standards than others. Cause of death has always been difficult to ascertain in the best of circumstances, let alone during a pandemic. In the UK, for example, we know that anyone who dies within 28 days of a positive PCR test is included, which leaves us in a position where we're unable to ascertain who died of COVID and who died with it. Of those who died of it, we don't know how many would have died anyway. Mortality displacement is very hard to quantify here. One of the curious things about COVID, the mechanism of which is not necessarily well understood, is that it has replaced flu in the recent winter. Flu seems to have largely disappeared off the face of the earth, whether a country has locked down or not. So the 95-year-old guy with heart trouble, who contracts COVID and sadly dies, we don't know whether flu would have taken him away instead, or indeed whether his heart condition would have sadly finished him off. In a way, it doesn't really matter who dies of COVID and who dies of something else. The ultimate aim is to save lives. For example, if a new special disease appeared from hell that was guaranteed to kill all lung cancer patients in the world 5 minutes earlier than they would have otherwise died of lung cancer, we wouldn't want to spend time trying to prevent this. The death certificate would say they'd been killed by the devil rather than dying of lung cancer, which would be fascinating from a medical statistics point of view, but irrelevant to virtually everyone else. So the best measure in the final analysis would be excess all-cause mortality, which is the total number of extra people who died in each country on top of what we would normally expect. Even this isn't perfect, because what we would normally expect in terms of mortality needs adjusting for mortality improvements, and it's not clear what these should be, or indeed whether COVID should be viewed as a blip in otherwise improving mortality. I'll say more about this later. However, despite this problem, I think it's clearly still the best measure in the final analysis, and I would like to see evidence produced of the negative correlations we would expect under the lockdown works hypothesis. Another criticism I want to make of my own analysis is the figure that I've used as a proxy for lockdown severity. So this index has been put together by Oxford University, and it tracks the lockdown severity of each country over time, according to factors such as school closures, workplace closures, restrictions in movement, cancellations of public events, closures of public transport, stay-at-home requirements, and international travel rules. Here is the one for the UK, for example. It was difficult to know which figure to use. Average might seem like a fair way of doing things, but this would be flawed, because, for example, New Zealand had a very severe lockdown. It was perceived to have worked, and then they went back to normal. So if I used average, it would unfairly assume that New Zealand had a mild lockdown, when this is not true at all. New Zealand's figure included in my study should be the severe one that was perceived to have worked. So I used the maximum number for each country, which I think it's fair to argue is a pretty good proxy for that country's overall lockdown stringency. It's not perfect, of course. For example, the maximum lockdown severity for the UK was 81.48, which you can see here on the red line. One might argue that the only reason the UK's COVID death toll was so catastrophic was because of all of the places on this graph you can see where we were below the red line. You may see this as more pronounced in some of the other countries. I didn't check every single one, so I make this criticism of my own analysis. However, we still seem to be waiting for an objective measure of lockdown severity that we can compare with COVID deaths per 100,000 and find the negative correlation we would expect to see under the lockdown works hypothesis. I'm not saying this measure doesn't exist, but I am saying that we need to see it. We have 1 year of data now. With the way our lives have been turned upside down, I think it's fair to ask, where is this evidence of correlation? One might be tempted to dismiss my findings in light of my own admission that the analysis is very basic. It's much more nuanced than that, right? Well, it wasn't much more complicated when we looked at the obesity figures. That was a very basic analysis, just one simple figure from Wikipedia that showed a very clear, strong positive correlation between obesity rates and COVID deaths. But if you're looking for analyses that are less basic, the world of science can oblige you. Summer 2020, published in The Lancet. This study did a less basic version of what I did, measuring the impact of government actions. Same conclusion. Full lockdowns and widespread COVID-19 testing were not associated with reductions in the number of critical cases or overall mortality. There are many other published papers with similar conclusions. Summer 2020, Cornell University, suggests that infections in the UK were in decline before full lockdown. May 2020. These strategies might not have saved any life in Western Europe. July 2020. We found that closure of education facilities, prohibiting mass gatherings, and closure of some non-essential businesses were associated with reduced incidence, whereas stay-at-home orders and closure of all non-businesses was not associated with any independent additional impact. August 2020. This is a research university in Denmark. Comparing weekly mortality in 24 European countries, the findings in this paper suggest that more severe lockdown policies have not been associated with lower mortality. In other words, the lockdowns have not worked as intended. September 2020, published in the British Medical Journal. The findings of this study suggest that prompt interventions were shown to be highly effective at reducing peak demand for ICU beds, but also prolong the epidemic, in some cases resulting in more deaths long term. This one's also September 2020, published in the British Medical Journal, and it focuses specifically on Belarus. The president has flatly denied the seriousness of the pandemic, refusing to impose a lockdown, close schools, or cancel mass events like the Football League or the Victory Day Parade. Yet the country's death rate is among the lowest in Europe. November 2020, New Zealand Economic Papers. Lockdowns do not reduce COVID-19 deaths. December 2020, published in Nature. The conclusions with regard to the effectiveness of individual MPIs are not justified. Although the MPIs that were considered have indisputably contributed to reducing the spread of the virus, our analysis indicates that the individual effectiveness of these MPIs cannot be reliably quantified. January 2021, published in the Social Science Research Network. Lockdowns had only a small effect on COVID-19. I think it's fair to ask why the mainstream media are not making the public aware of all these papers and their conclusions, which run contrary to the government narrative. We're told again and again that the government is following the science. Talking about science in this way, as if it's some kind of law handed down from above, is the antithesis of what science should be about, which is the constant discussion and search for the truth in the form of postulating theories and increasing our confidence in them as attempts to disprove them fail. Instead, we have no discussion, no debate. It's really hard to see how a balanced decision was reached in this environment. On that note, should you choose to do your own research, I would urge you to be aware of the poisoning of the well, a phrase that derives from the ancient wartime practice of pouring poison into fresh water sources before the imminent invasion of an attacking army. Negative information is presented about a person to an audience with the intention of discrediting what he or she intends to say to that audience. I give a fictitious example of an ancient Greek determined that the audience not listen to the undoubted truth of Pythagoras' theorem because of something he may have got wrong about squares previously. As an example, I found this article in the Times from September 2020, explaining why the Imperial College model of the way the COVID virus was going to pan out should not have been used. It opens up with Neil Ferguson's horrendously bad 2005 prediction of the number of people worldwide who would die of bird flu. I'm not saying we should ignore bad track records, especially ones that indicate overconfidence in one's own ability, but this simply isn't how science works. Neil Ferguson and Imperial College's model is almost certainly wrong on COVID because the emergence of the data has almost certainly shown it to be wrong, not because they were wrong last time about bird flu. Cue as an example Neil O'Brien, an ambitious MP on a McCarthy-style witch hunt, who decided to put together a blacklist of the scientists that he claims are spreading disinformation. Notice the kind of language that permeates the mainstream press. COVID skeptics, lockdown deniers, conspiracy theorists, a continually employed sleight of hand to subtly lump together anyone who disagrees with lockdown as an approach with lunatics who might deny that COVID even existed or think that 5G might have something to do with it. Notice though, if you choose to look up this blacklist, that Neil Ferguson and his horrendous track record of modelling didn't make the list. Don't get me wrong, Neil O'Brien is by no means alone when it comes to this persistent underhand tactic to shut down any debate on the topic of whether lockdowns should ever have taken place, and I certainly don't want to make this a party political issue. I believe that the much-needed debate has been lacking across the whole political spectrum. If you Google many of the scientists who are speaking out very strongly about the efficacy of lockdown, from Nobel Prize-winning biophysicists to long-standing professors of epidemiology at top universities, you will find it extremely easy to find the well very well poisoned. I would urge you to listen to what Carl Hennigan, lead professor of evidence-based medicine at Oxford University, has to say on this subject. For those who are not interested in what the lead professor of evidence-based medicine at Oxford University has to say, like the UK government for example, you do have to again wonder how a balanced decision was ever reached. Let's go back to looking at the simple graph I showed at the start. Recall that it shows the number of deaths per 100,000 people between different years in a way so that you can compare them fairly without having to worry about the age profile of the population. Again, you can find these figures on the government's ONS website. So let's see what this graph looks like for 2008 until 2020. You can kind of see the mortality improving over time, with the impact of COVID pretty clear in 2020 as a nasty year. It looks more dramatic in this graph, because notice that the scale of the graph starts at 800. We'll see this graph again in a bit without it being truncated, but either way, it's clear 2020 was a nasty year. Something that's frustrated me throughout all of this is the assumption that anyone who is against lockdown as a policy is somehow uncaring or feels the sadness of these extra deaths less keenly. I would urge that if we want to reach a sensible conclusion, the starting point in any debate should be to acknowledge that each side is benevolent. So 2020, a nasty year for sure, but is it the Armageddon we were sold back in March? The deaths per 100,000 people is lower than in 2008, and indeed every other year before that, as we shall see soon. Do we really think a response as extreme as a year of lockdowns was proportionate? Now, of course, we're then told the death toll would have been even higher were it not for lockdowns. This might be true, but the certainty with which it is often declared is a concern, to say the least. This is a good point to explain falsifiability. Falsifiability is widely considered as the hallmark of a scientific hypothesis, a principle that science thanks the philosopher Karl Popper for. Surviving falsification is an idealization of the scientific process. Science works by us making hypotheses and increasing our conviction in their truth as we fail to prove them wrong. So if there isn't a way to disprove a statement, it's not really a scientific hypothesis. Examples include, if I'd stayed with my husband, I would definitely be happier than I am now. Whilst the woman who says this may feel it to be true, with every passion in her body, we have no way to ever know if it's true, because there isn't a parallel universe to compare where she stayed with her husband. My parents smacked me, and it never did me any harm. Again, we have no way to know, because there isn't a parallel universe to compare. Lockdown measures in the UK flattened the curve. When we had the first wave of COVID in March 2020, the peaking of the curve was attributed to the lockdown measures put in place 3 or 4 weeks before. But we don't know if the curve would have just turned over by itself in exactly the same way it did in Sweden, a country with no lockdown. For the various subsequent lockdown measures, the curve didn't respond 3 or 4 weeks later in the same way. Whenever the curve was going up, we were told we needed more lockdown. Whenever the curve was going down, we were told that the lockdown measures were working. This is called the cum hoc ergo propter hoc fallacy. Since event Y followed event X, event Y must have been caused by event X. There is no parallel universe where we didn't lock down, so we'll never know. But we can look at countries that didn't lock down for examples of what might have happened. If we look at the number of deaths that occurred in Sweden, we see that it was about 5% higher than average for the last decade. It's important to note here that this is the actual number of deaths in Sweden each year, so no attempt has been made to adjust the age profile or population size. Both population and age profile in Sweden have been reasonably stable, so this isn't a big deal. We might see 4% or 6% instead, say. Again, it's a nasty year, but it's hardly Armageddon. The classic counter-argument here is that Sweden has a lower population density, or a health service better set up to cope. Okay, let's instead look to Japan. Nearly twice the population of the UK, a very aged population, and a country with the largest city in the world, Tokyo. The lockdown measures in Japan were extremely mild, and yet only about 7,000 COVID deaths have been recorded. As an aside, if Sweden's health service was better set up to cope, why wasn't ours? And what are we going to do about it? I'll emphasise this point again later. Many countries had no lockdown or very light lockdowns and did not have the catastrophic death toll we were all told would happen. Sweden, Japan, Taiwan, Tanzania, Burundi, Nicaragua, Belarus, Paraguay. Many US states had differing levels of lockdown with similar death tolls regardless. North Dakota and South Dakota both have very similar geography and demographics, and both have sadly fared very badly in terms of COVID deaths. North Dakota introduced many interventions, yet their mortality curve continued to move seemingly autonomously and in sync with South Dakota, who did not introduce these interventions. Florida and California, 2 of the 3 most populous US states, also both have very similar geography and demographics. California has very strict lockdown policies, whilst Florida last year relaxed the lockdown measures to the extent that life is pretty much back to normal. Both states have extremely similar curves for death rates. On the other hand, we see that many countries had very strict lockdowns and very low mortality. New Zealand, Australia, South Korea, Laos, Uganda, Vietnam. So what are we to make of all these conflicting pieces of evidence? Well, we really need to look at the overall picture and see if there's a general trend, in spite of the odd counterexample. For example, Let's try to predict the weather by tossing a coin each day. Heads means that tomorrow it will rain, tails means that tomorrow it won't rain. How will this go? When we look at the overall picture, there will not be any correlation. The tossing of the coin has nothing to do with whether or not it rains the next day. One of the problems we've got with the hypothesis that lockdown prevents COVID deaths is that intuitively it's a very sensible thing to hypothesize. We know viruses transmit through human contact, so if we stop the human contact, we stop the virus. It's obvious, right? In fact, it's so obvious that many of us, including me at first, just assumed it was true without even questioning it. Well, obvious perhaps, but it's still a hypothesis, and it needs testing. And when we test it, these are the results. All the Swedens and Japans, as counterexamples to the New Zealands and Australias, are balancing out to the extent that there's hardly any correlation between maximum lockdown severity and COVID deaths per 100,000. You toss heads, sometimes it rains, sometimes it doesn't. You do a lockdown, sometimes you get low mortality, sometimes you get high mortality. There's no real pattern. It's a very counterintuitive result. It's very surprising when you consider all of the things we've been told on the news. But there simply isn't the evidence here that lockdown impacts COVID deaths. I'm not saying it's impossible to provide an objective measure of lockdown severity that gives us different results, but I am saying that we're still waiting to see such a measure. We're still waiting to see credible evidence for the efficacy of lockdown. Pointing at a graph of deaths in one country curling over and saying, look, is simply not good enough. It's cum hoc ergo propter hoc. Now there's something else I'd like to point out, perhaps a circular argument being made by many people that hasn't been spotted. Here is the graph of the number of deaths in the UK from 1981 to 2020. Again, this has been standardised for age. Again, 2020 is a nasty year, but is it Armageddon? Every year from 1981 to 2008 saw higher deaths per 100,000. Let's plonk on the mortality improvement that I think probably partially explains this. But why do I only say probably? Well, mortality improvements aren't guaranteed to continue indefinitely. In fact, they can't. It's more correct to say that mortality changes over time, we observe how it's been changing, and then conclude that mortality improves once we've seen it improve. If you look at the graph, you might say that it looks like mortality improvements in the UK have slowed down, and perhaps even ceased over the past decade or so. It's actually extremely difficult to make any definite conclusions on this, because there are so many changing factors from one year to the next. But the point is that it's possible that mortality improvements have slowed down. It's even possible that 2020 is the first year in a new trend of mortality worsening. Let me explain this in a different way. We're treating COVID as a blip in otherwise improving mortality, which may well turn out to be the case. But let's think back to where the mortality improvements since the 1980s came from. Improved medical care, frequent conquest of cardiovascular disease in the elderly, improved cancer diagnoses and treatment, improved treatment of pneumonia in the young, prevention of death caused by low birth weight in infants, smoking cessation, better diets, etc. Hang on a minute. Better diets? Between 1993 and 2020, we've seen the obesity rate double in the UK. We've seemingly ignored as a nation the repeated warnings about how we're heading towards times of lower life expectancies. Yet when the first empirical evidence of this emerges in the form of a deadly virus that we've seen for a fact causes high death tolls in countries with high obesity rates, we seem surprised. We don't have a God-given right to improving mortality. We need to keep doing the things that contributed to it in the first place, one of which was better diets. Have we reached a point where our dreadful diets are starting to undo all the good work of the other items on the list? COVID is a virus from nature. It's not a one-off man-made catastrophe. The 2020 excess deaths just might be indicating the start of a new trend in the temporal shift in mortality, not necessarily a blip in otherwise improving mortality. The government and the mainstream media portray COVID very much as a one-off alien invasion. There is very much a Hollywood movie narrative to it all. But the less glamorous yet simple truth could be one of an evolved pathogen taking advantage of a systemic vulnerability that we've created for ourselves. In other words, what did we expect was going to happen if we kept ignoring the warnings about our unhealthy lifestyles and the high obesity rate that confirms them. Okay, so what did we do? Imagine with the benefit of hindsight that we're in a very important government meeting on March the 22nd, 2020, and we've decided that we must do something extreme. Are you sure? The evidence that something extreme is needed seems flimsy. Sweden aren't doing anything extreme, and they have 5% extra deaths. Nasty, but hardly justification for something extreme, surely. No, we must do something extreme, something that would only ever have been imaginable previously in a totalitarian regime, something that confiscates basic human liberties that we've become accustomed to in Western democracy. And we must scare our people so that the masses coerce anyone sceptical about what we're doing. Make sure that you write this down on an official document too. I'm not sure why, just make sure we leave a trail on that one. Okay, well if that's the mandate, let's do something extreme. Looking at those correlations, seems like if we have to do something extreme, it should be to do something about our unhealthy lifestyles and the associated obesity, like an immediate attack on the sugar and fast food industries. We could ban all fast food restaurants, ban supermarkets from having more than one aisle of junk food, ban junk food in petrol stations, ban cakes in coffee shops, ban processed food, make all special offers on junk food illegal. We could subsidise special offers on expensive healthy foods and all children having healthy meals from now on. We'll need to temporarily support all the ordinary people who lose their jobs in the sugar and fast food industries until they find new jobs or until the savings on NHS treatment filter through. So to pay for it, we'll use the £400 billion that we're about to spend on something extreme. And if we've got any spare cash at the end, we could use it to actually staff any hospitals that we build as publicity stunts, so that we're better able to cope with the inevitable rise in cases next winter. No, I don't care much for correlations or evidence. I prefer common sense. Stop the spread and we stop the virus. We'll do lockdowns. What about all the known costs, suffering, misery, and eventual human deaths? We'll worry about that later. We haven't got time to have a proper cost-benefit analysis now, or in fact later. So come into the supermarket. Sanitize your hands, follow all the arrows, stay away from people, and stand here until you're told to stand somewhere else. But make sure your trolley is full of cut-price junk food. And here is some more cut-price junk food at the checkout, in case you forgot to put it in your trolley already today. Thirsty? What colour would you like your sugar to be today? Don't forget the Easter egg aisle, or the crisp aisle. Don't just go to the supermarket though. Visit fast food restaurants, remembering social distancing, of course, to stay safe. Or maybe go to the pub, wearing a mask from the front door to your table, and then take it off to eat something more healthy than fast food. Or just go and grab a coffee with a friend, and why not have a cake whilst you're there? And if you forgot to buy any of that rubbish at the supermarket, why not instead grab something when you pay for your petrol? Marketing of junk food exists because it works. Many unhealthy people never stood a chance. How is a single parent on universal credit meant to navigate his or her way through a supermarket and come out with a trolley of affordable healthy food? Or even if we ignore the power of marketing and charge all adults with the responsibility to make their own choices on diet, how are children, especially those from poorer families, meant to make it to adulthood without becoming overweight or obese? We've had about a decade and a half of being told that our unhealthy lifestyles and the associated obesity are a problem. Life expectancy is going to go down unless we do something. The blame seems very much on the obese individual and his or her individual responsibility. I'm not saying that people are exempt from individual responsibility, but when you have the worst obesity rate in Western Europe, it is a catastrophic failure of state. Obese people need help and support. Where was it? Protecting the NHS is well-meaning, I'm sure, and a great new slogan. But where were the attempts to save it from the rising cases of type 2 diabetes and the other problems associated with the obesity crisis over the last 2 decades? Where are the dramatic results of Jeremy Hunt's 2016 promised game changer? Seriously, what did we do? The benefits versus the costs of a really decent attempt to genuinely reverse the trend in our bad diets and the associated obesity rates. I mean, do I really need to make a slide? The benefits of lockdown, on the other hand, I've already shown are very unclear. The hypothesis that it significantly impacted COVID deaths is extremely weak. But what about the costs? Well, it's a catastrophe. Depression, increased drug overdoses and suicides, hunger and poverty, recession, business closures, job losses, increased disparity of wealth, increased crime, misdiagnosis of critical conditions such as cancer, decreased quality of life from delayed routine medical procedures, increased obesity from keeping people indoors. It's actually possible that lockdown caused more deaths in respect of COVID. I'm not joking, this is a credible hypothesis. Education grinding to a halt. And there's one other cost I would like to add to the list, one that seems to have been largely overlooked, and yet one that I think might be the biggest cost of all. Let me explain by first giving you some bad news. You are going to die. I'm sorry if you didn't realise that, but it's true. One day you're going to die. I'm going to die. This is my remaining timeline. On the 23rd of March 2020, I was 42 years old. I'm a pretty fit person, so I've decided I'm going to live until I'm 100, which means I had 58 years left at this point. My plan is, and always has been, to spend the few years I have left cramming in as much as possible, enjoying myself as much as I can, and bringing happiness into other people's lives whilst I'm here. Soon, it will be the 23rd of March 2021, at which point I'll have 57 years left. Now, whether I'm right or wrong with my optimistic assessment that I'll live until I'm 100, I have lost 1 year of my life. You have lost 1 year of your life too. Let's revisit what it means to kill. To kill is to forcibly remove years from a person's life. If we assume that all lives are equally important, and that any individual person's future years are equally important, it doesn't matter which years you remove, it's still killing. Now, it's nowhere near as simple as that, because we've all lived through the last year. So the question is then, how has the last year been for you? 80% enjoyment perhaps? To help you answer that question, imagine you could go back a year in time and be offered a deal by the devil, whereby instead of experiencing the year of lockdowns as you just have, you could instead experience 10 months in a normal world of no lockdowns, and then click your fingers and 2 months just goes. You just age by 2 months in an instant. Would you take such a deal? Then work out what your equivalent point is. So for example, if you would just as happily have had 9 months normal, plus 3 months lost in an instant, as have lived the last year as we did, this would give you a 75% enjoyment factor. Another way of saying this would be that 25% of your last year has been killed. My enjoyment factor is very low, maybe as low as 50%. For some people, the last year has been absolutely horrendous, possibly to the point they would rather have had all 12 months deleted, hence a negative enjoyment factor. At the other end, I have one friend whose own life he believes has actually been better during lockdown, and hence an enjoyment factor greater than 100%. Chatting to many people about this question, the average seems to be about 80%. Now let's just ignore all the evidence I've presented so far, and assume that lockdown does actually work, and it saves the 500,000 lives that Imperial College's model predicted would die, on top of the 100,000 COVID deaths that we've had anyway. Let's make a generous assumption that each of these lives had about 5 years saved. The average age of people dying of COVID is higher than the average age of people dying normally, so 5 years seems pretty reasonable. This would mean that we've saved 2.5 million people years. If we take the 67 million people in the UK who didn't need saving, and an 80% average enjoyment factor for the last year, this means each of these people has been killed by 20% of 1 year, which equates to 13.4 million people years killed, more than 5 times the number of people years that we've saved, even if lockdown works. Even with an average enjoyment factor for the last year of 96%, we've still killed more people than we've saved. And I think we can say with absolute certainty that the average enjoyment of people's lives over the last year compared to normal is not as high as 96%. I've never understood why this very obvious cost-benefit analysis alone didn't just have us dismiss lockdown right at the start. When COVID struck, many extra people years were sadly going to be lost, but we had a choice as to which ones, and it seems to me that we've catastrophically gone with the option that kills more people years overall, even before you consider the other costs. Life is for living, not safeguarding in order that we may live it later. For millions of people, the last year hasn't been life, it's been existence. We've been keeping ourselves breathing in order that we may live the rest of our lives when this is over. We've been treating the problem very much as once we save all these lives, we can get back to being immortal. Well, I'm sorry to repeat the bad news, but you're not immortal, and you're now 1 year closer to death. That year is gone, and you are never getting it back. What did we do? As I add this cost to the list, my heart goes out to those who've not only lost that year of their life, but now also have to pick up the scraps of what remains from the damage inflicted by some of the items above. My people years argument has lockdown failing the most basic cost-benefit analysis, even before you add on these extra costs. If you're looking for something less basic, the world of science can once again oblige you. This analysis, as just one example, was put together by Ari Joff from the Division of Critical Care Medicine at the University of Alberta in Canada. It produces a cost versus benefits balance sheet based on well-being years. Its author explains how the analysis caused him to change his mind quite drastically on the efficacy of lockdowns, demonstrating that even under the most generous assumptions in favour of lockdown policies, the costs were still 5 times greater. It's a very thorough analysis, and I recommend you have a look at it. One question that I'd like to ask anybody who works in medicine is whether they're satisfied that the Hippocratic Oath has been adhered to in all of this. If we're looking at the efficacy of a new drug, because we're hypothesizing causation, we assume there is no causation until the results of a double-blind trial indicate that it's statistically significant there is some. We don't just let the drug go out to market because of all the harm it could do. Why does this principle change when we're talking about non-pharmaceutical intervention? If we're looking at the efficacy of a new non-pharmaceutical intervention, surely because we're hypothesizing causation, we should again assume that there is no causation until we see some evidence. We shouldn't just let it go out to market because of all the harm it could do. In the case of national lockdowns, it wasn't about the harm it could do, it was about the harm that it inflicts with known certainty. Yet it seems that we release national lockdowns on our people with no better idea on their efficacy than a common sense slogan based on our limited knowledge of how viruses spread at a local level. It strikes me that the Hippocratic Oath has not been adhered to. In summary, were the costs really high enough to justify extreme action? A nasty virus, absolutely. Terrible death tolls in many countries. But was it the Armageddon advertised on March the 23rd? If so, should that extreme action have been national lockdowns? Many of the disastrous consequences of lockdown are known. Where is the evidence of the benefit? The correlations seem to suggest that an emergency attempt to tackle our unhealthy lifestyles would have had a much greater impact and a far, far lower cost. We could have kept society largely running, with perhaps an attempt at targeted protection of the vulnerable, like people in care homes. Even if we assume that lockdown works, where is the cost-benefit analysis? The benefits of properly tackling our bad diets and the associated obesity levels are enormous. Aside from the short-term cost of taking down the sugar and fast food industries, are there even any costs? With the vaccine rollout and the so-called roadmap, we now have some dates and some promises of when life will return to normal. Like everyone else, I long for a return to normality. I hope we finally come out of lockdown as per the given dates, we return to normal, and we never go back into lockdown. I want this presentation to die a slow death on YouTube, and for what I'm about to say to be viewed in 5 years' time as melodramatic hyperbole. But I'm extremely worried that a new normal has been created, whereby the majority of the nation is prepared to sacrifice their freedom at the drop of a hat, if they can be coerced through fear to do so. I'm extremely worried that in the face of the evidence, we've created a system where it's perceived that national lockdowns are a perfectly acceptable way to deal with the threat of any nasty virus. I'm worried that this could happen as early as next winter, with a variant of COVID that's resistant to the vaccines. I'm extremely worried that we'll continue to ignore the obesity crisis that I believe has been far more impactful in terms of COVID deaths outcome in pursuit of more lockdowns. And I'm extremely worried that even though we might reasonably expect there to be a high demand for hospital beds next winter, we will once again spend the summer doing absolutely nothing to prepare for it. I'm pleading with anyone who will listen to see this calamity for what it has been, and please help ensure it never happens again. The question is no longer what did we do, it's what will we do next.